I have a question for Dr. Canessa. Did you consider doing any sort of transclival approach? And did you transclival? Did you model that at any point? I understand the difficulties of doing that. You'd have to drill out the cella to some extent, mobilize the pituitary. You'd have a lot of problems with potentially with CSF leak control. But it looked like that would be sort of a direct approach in between the cerebral peduncles or in between the cortical spinal tracts to get to the lesion.
Yeah. Well, I think if the lesion was a little bit lower, then you would probably think about this. But it's in the upper points. It's above the trigeminal nerve, and really well, I don't know if it was very well seen, but if you take away the posterior clinoidal, then you have enough space. So that was what we thought of doing. But I think it would be a more formidable problem if this was really facing anteriorly and a little bit down, a little bit more down. That would be really very, very, very difficult, because from the lateral it would be you would always have some neural tissue in between, and going from the upper, maybe what you can do is at this point where the posterior clinoid has been resected, you can still keep on going with the drilling, but this is hard to say. I never had such a case.
I have a question for the panel. In terms of the educational implications of using such a tool, what do you see the possibilities?
Well, I want to second what Dr. Baltic said. It's sort of obvious the ways that this system can be applied for resident education, and for that matter, medical student education. I think at the medical student level, most likely you would use the system to teach anatomy, primarily normal anatomy, in a way that would be much more sophisticated and robust than simply looking at two-dimensional images on slides, even on a computer, or in an atlas of different kinds. At the resident level, you can really give a very rich experience of the three-dimensional surgical anatomy, which would include the scalp and the skull, again, in ways that residents don't normally do. One thing we didn't discuss here was show an application for use in spine surgery, but this would certainly be an outstanding system to model for a patient who needed a complex spine reconstruction, either in terms of the bony resection, but also the grafting and the instrumentation. I know my ENT colleagues already have a whole system that is basically in place where they have measurable effects of the Dextroscope on resident education. They're already starting to have residents do surgical modeling on the system before and after instruction and looking at the comparisons. The standard being the attending choice, of course, and seeing how far they deviate from that initially and how close they come to that afterwards. And we're going to institute a similar program with the neurosurgery residents.
Any other questions?
How's the fusion done between
the microphone?
How are the images fused between the multiple studies? The fusion between CT, MRI, MRA, how is that registered together?
Usually done with a method based on integration of mutual information. I don't know if you're familiar with those algorithms, which...
It's completely automated, though?
Sorry? It's
automated, or is there verification? How do you
well, for CT, MRI, co-registration, it's automated, completely automated. We have other data. In fact, we are now working on the data that Dr. Conessa was missing in his case, which is diffusion tensor imaging and subsequently tractography. And due to inherent distortion in that kind of data, you sometimes need some manual adjustments, which goes beyond what integration of mutual information can do. But within that virtual workspace, we have those tools which allow manual adjustments. But for a plain CT, MRI, MRA, MRV co-registration, it's automated.
The MRA and the MRV is just based on information in the DICOM that correlates it to the structural MRI?
That's it. Yeah, that's all.
Anything else?
And the segmentation, how's that done?
Well, the segmentation is usually threshold based. As I said in my case, I would say there's no such thing as complete automated segmentation. If you have a lesion, a clear lesion, which is on the gray-white ramp, can be segmented. We can do that. We can segment that lesion, that structure in a pretty much completely automated fashion. But the truth is that most structures in the brain and anywhere else in the body would usually require some kind of human refinement interaction to get the exact shape as you would assume it would look like in reality, and then you would want to make use of those erasing tools. So there is a bit of manual interaction.
So the skin, the skull, and the vasculature would all be automated, but then
the skin is automated. The skin is automated because it's easy. It's just, I mean, you make use of the threshold between air and signal, and that's easy. The vasculature is automated.
One of the I think advantages of this sort of digital world in DICOM imaging is I can take a DICOM image and send it anywhere in the solar system, and have someone segment all of that and send it back to me very quickly. So you don't have to do it yourself.
Have you had any experience with registering functional MRI volumes or tractography in the system and using that as part of your modeling?
Yeah, as I said, yes, we are doing that, and we have also co-registered task activation data and some perfusion and diffusion weighted images. Of course, now as everyone knows, the very exciting part is diffusion tensor imaging, and we also all know that there is more distortion than in a regular T1 or T2 MRI. So that's one of the challenges. If you're interested, we can show you some kind of a prototype of our DTI module, but we are not showing it here because it's not FDA approved and it's not currently part of the product. But if you're really interested at the booth, we can show you some of that ongoing work if you're interested.
Sorry, one more. Is there any way to use this with image-guided surgery systems that are in use now in terms of, once you've actually made the craniotomy in the OR? Can you use this?
Well, currently you cannot, you can't import or export the data into a commercially available navigation system. So it's a planning system, and you can make your plan as we have illustrated in a very nice and unique way. And what you can do is you can what we've done many times is in fact quite provides you with a lot of information. Is you can snapshot a lot of those situations and print them in red and green stereo, and you can take them to the OR. And in our OR in Singapore or in Mainz, Professor Pernetsky is using that system a lot. Nowadays, the wall is not just the CTs and MRIs in front of a light box, but next to it there's all the colored printouts from the planning. So you can simulate the different views, and you can have a red-green shot, and then you take your red-green glasses to the OR, and then you can, you have those impressions from the planning, available. However, the last thing is we have a poster on a navigation system. Yeah, it's also a poster. You can see that in this conference. We have built our own prototype of an augmented reality navigation system, but it's not a product.
Sounds like the short answer to the question is no.
Well, I should become a politician.
But it's a great question. Sounds like something that you really should work to and should be made available.
I'd like to say something I cannot help. I mean, what I think is that the virtue of this tool is the more complex the anatomy is, the more complex the relations, the more curvilinear, the more difficult to imagine, the more powerful that this thing is. So I imagine that placing besides this, it's already very nice to see a DTI in 2D or in a 3D. If you can see it stereoscopically, which is much more natural, you can explain this, but when you see the images with the glasses and the stereoscopy is then when you understand that. So really, the more complex, and fibers are very complex, then the more useful that this thing can be. And I'm really eager to see a presentation with these 3D fibers.
I would say that I agree with you. I think levering the system onto a navigational system is an obvious next step. You could also see doing things like radiosurgical planning would be an obvious, a next step. You could see sort of filling your, doing your radiosurgical planning on this type of 3D system and filling up the marbles as you fill up the, your dose shots would be another natural, intuitively, for someone who does functional work.
Further questions? Well, if not, I'd like to thank our panel and our presenters. They did a terrific job. This is the first time we've tried this in this kind of a setting here in the U.S., projecting the 3D and collecting the cases, and I think everybody did a great job, so I thank you very much. Before you leave, I'd just like to let you know that at your table you have a product brochure, a CD-ROM, which demonstrates the use of the product. You have a laser pointer that we're giving you as a gift, and thank you for coming tonight. So you're welcome to keep that. If you want to keep your glasses and show your kids or something what you did on a Saturday evening, you have the 3D glasses. If not, you can leave them. But more importantly, we have a two-page, just a few questions survey, and I would really appreciate you taking a minute to fill out the survey. As I told you, we're just now on the precipice of launching this product as a commercial product in the U.S. We're looking for your input and your feedback, and if you have any further questions about the product, we'll be at the exhibit on Monday, Tuesday, and Wednesday at Volume Interactions, and please feel free to stop by, and people from Volume Interactions will be there to answer your questions, as will I. So thank you very much. I appreciate you taking the time. Thank you.